Welcome to the webinar Dilemmas in Contraception. I think it's a very interesting and exciting webinar. We are discussing together today questions which are of high importance from a scientific point of view, but also from a practical point of view. As you have seen on the flyer, we have really two eminent speakers for this webinar. And I'm really quite proud and happy to have been invited as moderators. Very briefly through the program, the first talk will be by Ali Kubba. I don't have to introduce him, but I do, because he's the Vice President of the European Society of Contraception and Reproductive Health. He's lead consultant in colposcopy and reproductive health care in Guy's and St. Thomas National Health Service. Foundation Trust, London, in the UK. And as you know, Ali for many, many years has been extremely active in the field of contraception. The second speaker is the world expert on emergency contraception. I mean, you all know her, Anna Glasier. She's honorary professor at the London School of Hygiene and Tropical Medicine and the University of Edinburgh, United Kingdom. She has spent her life really in research on reproductive health, particularly in contraceptive development and the delivery of contraceptive services. So it is on one hand clinical trial research, but also on the other hand research and work on how to provide best quality services. So as I said, we are very happy to have these speakers here. Let's briefly do some talk about the practicalities. When you have questions, please activate the question and answer sign at your screen. Click on that button and your questions will be registered. Please add your name and country when asking a question. You can, for example, upvote each other's questions if you click on the thumbs up sign that you find this is a very important question. We will, of course, select, maybe we cannot answer all the questions, but we will select some of them and it will be addressed after both lectures. Those we cannot deal with, we will answer them later to the and publish them to the people who question it. As I said, unanswered questions will be addressed and added to the ESC website. This is all in the context of the educational efforts ESC is doing, also in these times where we cannot have face-to-face meetings, where we could not have the Congress. So we are very much involved now in trying to develop new media, new forms of communication, new forms of communication. And one of these possibilities is that you connect to ask questions or submit comments and follow the conversation after the webinar by using the doc matter com of ESC. This is something which now works for already some time and where very interesting exchanges happen. The ESC doc matter community is a benefit of the ESC membership. So if you are a member, and I would again really encourage you and invite you to become a member, to use this media to get in communication, ask your questions, get the input of experts from all over the world actually, and thus improve our communication and education. Now, when you look at what is going on that doc matter platform, we have now ongoing discussions about the access to reproductive health services. We have ongoing discussion, the impact of COVID-19 on patient care. We have, of course, all sorts of questions about contraception There is an ongoing discussion about ovarian and breast cancer, of course also risk in the context of contraception. There are very interesting exchanges because people make different experiences in different countries about patient education and remote consultation, virtual consultation. And at DocMatter, you can discuss cases, you can ask questions, you can point to emerging evidence, interesting publications you have read, and even more. So I really want to encourage you, become member if you are not, and use DocMatter. The next thing I would like to stress again is this issue of membership. We really depend on our members, and I think the members are a real, how can I say, backbone of a society. Here is, again, you can see the application, how you can do it. You can see the membership fee is very low. I think it's the only society I know with such a low membership. And some of the benefits are you get six free editions of our journal, which I can recommend, of course, very much. You get regular newsletters, you get free access to Congress presentations, webcasts, and e-posters. You get reduced Congress registration fees. You can stand for election to the board representing your country. And you have, as I mentioned before, access to DocMatter. So it's a society which is very alive and which is also, if I may say, really affordable and really dedicated to serve the members. Another maybe final point I would like to make just before we start the talks. I really want to point to our next Congress, as you may know, probably know, the Congress in Dublin had to be cancelled due to Corona. Now we are planning and working very much on the 16th Congress of the ESC, which will be held on the 1st to the 4th September 2021 in the beautiful city of Ghent in Belgium. Of course, we are looking into possibilities if there is a Corona problem, whether it could be a hybrid or a virtual meeting. But anyway, for the moment, we are planning, of course, to have a face-to-face meeting in Ghent, in this really very beautiful city in Belgium. So now let's go for our first talk. Ali Kubba will address interesting cases about contraception in the perimenopausal woman. Thank you very much, and please, Ali, take the floor.
Thank you very much, Johannes, and thank you for the introduction. And indeed, I am privileged to be part of this webinar with such eminent people in the reproductive health, Johannes and Glasier. Can I welcome you on behalf of the European Society? I work in London. You have my email if you want to email me. And I'm going to talk about the contraception in the perimenopause, illustrating some very simple case studies. So this is, in a way, the warm-up to Anna's presentation. It's more a jobbing sort of gynecologist type presentation. I use images in my presentation, so this is just to you know, keep your attention if the topic is boring. This is Big Ben, and St. Thomas's Hospital, which is where I work, is just across the bridge from Big Ben. So we're trying to, okay, and this is my declaration of interest. And this is the presentation overview. The image here is Barbie doll. As you know, Barbie is now 65, but she looks quite well because I think she's essentially prepared herself from her perimenopause. The case studies are supposed to highlight contraception or a request for contraception as part of a package of care. This is a transition era which will impact on a woman's life for decades. As you know, the average age now is in the 80s, and therefore half of the life of a woman is spent in the perimenopause and the menopause. So the slogan we use, this is the beginning of the rest of your life. So make the best start now. And I think in dealing with a request for contraception for someone in the perimenopause, we should not compromise. We should not accept that this is the way nature is. We should really aim for absolutely the top quality of life and quality of existence. And therefore, if there are problems, and sometimes you may need to, in a way, tease out these problems from your patients, then you need to do everything possible to sort them out. Contraceptive choices in the perimenopause are plenty because age is rarely a contraindication. If you go to the WHO medical eligibility criteria, you see actually quite limited contraindications which are based on age alone. So what are the concerns, the general concerns in the menopause transition? Contraception is one because pregnancy could be a disaster for a woman in her 40s, and therefore you need to look at priority as far as controlling her fertility and aim for the best and most effective contraceptive. Fertility may still be an aspiration, and as you know, in this country, definitely in the UK, a lot of women are freezing eggs or freezing embryos and delaying their fertility, and this needs to be addressed. We should give the woman some realistic expectation of what her fertility may be in her 40s. It is an issue. There are quality of life issues. So stamina, having the energy to carry on doing the things she does physically as well as mentally. Making sure this is when we need to put our health promotion on to reduce the risk of cardiovascular disease in older age and keep the bones healthy. I think mood and mental health are very important, and being on top form, as I say. I have a number of patients who are in this transitional phase, who are managing directors in companies, chief executives, so on. And at this stage, they actually want to be in top form because of their position and because of their responsibilities. And I had a patient who says, I look after a company of an office which has 25 people. They come to me for their problems. I don't want to have problems that make me a bit vulnerable. I think sex is important, quality of sex, sexual fulfillment, physical issues such as dyspareunia, which may surface even at this early stage in the reproductive phase in relation to the menopause. I think reviving relationships are important because a couple could actually start going through a phase where intercourse becomes less frequent, and therefore they technically lose the habit. A number of my patients say, I'm not having sex, I've lost the habit. So we tend to highlight that sex is therapeutic. It improves the circulation in the vagina, it helps keep things healthy, and the slogan, if you do not use it, you lose it, applies in this situation. This is a time for making sure that the woman is gynecologically well, managing abnormal uterine bleeding, talking about cervical and breast screening, and looking for any red flags in relation to gynecological cancers. And of course, a lot of women may come talk to you about contraception, but they have unspoken concerns: sexual dysfunction, incontinence, both urinary and fecal. Women who have discharge, have a smell, and as you know, the vaginal pH tends to become less acidic as estrogen drops, microbiome changes, they are more likely to, for instance, get bacterial vaginosis, and that might cause stress. But also think of the situation here in the UK where STIs in the over 40 age group are actually rising because of changes in relationships, finding new partners, and also genital prolapse. So we have three simple cases really to highlight this package that we need to offer a woman who presents to us. So this is a 44-year-old woman who has been using the progesterone pill for 4 years and comes saying, I want a pill to save my problems, solve my problems. And what are her problems? Well, her cycle is getting shorter, so she's getting slightly more frequent periods, though they're still regular, but it's getting heavy. This, I think, is her main problem: vaginal dryness and painful sex. We know she's a non-smoker and normotensive. So let us look at what are the issues in this consultation. So the first question is, she may ask, is this the menopause? And of course, what we would say, well, you're having regular cycles, and that goes against the diagnosis of the menopause. However, we know that estrogen levels drop a long time before the last period. So relative estrogen deficiency may be contributing to her symptoms. I think anybody coming in the mid-40s with an issue around sexual function, we need to think about relationships, we need to think about psychosexual aspects. They may have older partners, they may have younger partners, and the dynamic needs to be explored. We need to think about any other symptoms. A woman may come and say, you know, I'm not having an easy sex life, I'm feeling stressed, but she may also, for instance, not sleeping as well as she used to. She may be in a way feeling cognitively less able to do things. So exploring other symptoms that may suggest estrogen deficiency is also important. She's on the progesterone pill and she will come to ask, you know, is this the pill I'm on? In my view, the progesterone pill, because it uses a fairly small dose of progestogen, it is not very likely to be contributing, for instance, to someone who is starting to have some menopausal symptoms. The other question, people come and say, oh, check my hormones. You know, I need to have hormone tests to know where I am. And as you know, most of the authorities in this area say that hormone tests may be misleading and they are not really helpful, neither in a way in the prognostication of what happens to a woman in the perimenopause, nor in deciding what the treatment is, because they fluctuate. When you check them today, you're essentially having a one-day reading of the hormone levels, and they may change tomorrow. Can she switch to the combined pill? Remember, she comes and says, I want a pill to solve my problem. And my guess is at 44, she was probably switched from the combined pill to the progesterone-only pill at the age of 40, because her gynecologist, the person who was looking after her, thought, well, she's going over 40, can't use the combined pill. And that is wrong, because all the medical eligibility criteria we know, the UK ones, the WHO one, allow the use of the pill to the age of 50. So let's look at her contraceptive choices. Should we consider changing the POP? Well, we think that the POP, in my view, may not be contributing to her symptoms, but remember, we have new options in progestogen-only oral contraceptives, and we will discuss them later. Mirena is a friend of the perimenopause, and therefore it is an option that we may consider. A copper IUD, of course, for a 44-year-old woman, it's a single procedure and she can keep the IUD until the menopause, so it's good value for money, fit and forget. But remember, her periods are getting heavier, so a copper IUD may make them more heavy. We've already said that she can use a combined hormonal contraceptive as long as she does not have any medical factors which contraindicate them. Depo-Provera, well, I think a woman who has used Depo-Provera and wants to continue with it is fine. Again, we need to do a bit more in-depth counseling, but in my view, it is not a first priority. Implants are as good as the progesterone-only pill in the sense of the profile. They are much, 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 much more effective. And barriers are always good for backup. So what are the options for this patient? We need to talk to her about the options. That is very important. So she can carry on with her progesterone-only pill. And if we think she needs hormone therapy, we can give her a sequential combined method, because the POP doesn't give endometrial protection. And the hormone therapy will deal with her symptoms. Her pill will continue to give her contraception. She may say, well, I don't want to use hormones, in which case, if the main problem is the vaginal dryness and the dyspareunia, then local estrogen, whether tablet, cream, or ring form, would be quite good, and it has very limited, very little systemic absorption, and therefore it is safe. But also the use of moisturizers would be a very good option. We use lubricants during intercourse, but these do not moisturize. So we need to think about using a proper moisturizer. She can definitely go on the combined pill. And of course, as we said, Mirena would allow a number of things. One, it will deal with her heavy bleeding and would allow you to use systemic estrogen without needing to use a backup progestogen, because Mirena gives endometrial protection. So let us look at the issues around contraception that this highlights. You know, people come and say, am I too old to use this method or that method? We've already said age alone is not a contraindication to any of the methods. And I think women and many clinicians may have misconceptions about the contraceptive choices. And I encourage you to go to the WHO MEC, the FRCOG, the UK MEC, which is on the Faculty Sexual Reproductive Health website. Remember that in the UK, for instance, the rate of TOPs in the over 40s is relatively high. In absolute numbers is small, but it is as high as it is in teenagers. So we should not ignore the importance of effective contraception. The question that a lot of women will ask is, when do I stop contraception? So if menopause is diagnosed under the age of 50, a woman needs to use her contraceptive for 2 more years. If she reaches the menopause over the age of 50, then 1 year. How do we diagnose the menopause in this transitional phase? Where amenorrhea is one sign. If a woman has symptoms, be it vasomotor symptoms or psychological symptoms. What about measuring her FSH? Would only be useful really in selected cases. For instance, if someone is using a contraceptive that is already causing amenorrhea and comes with non-specific symptoms, and you want to know where she is. When to do these tests in someone who's using contraception? If she is on a combined hormonal methods, for instance, on the pill, many people feel that at the end of the hormone-free interval, the 7-day free interval, you can do check her FSH. You may need to stop the pill for a very short period, be it, a couple of weeks. With Mirena, with the POP, with an IUD, with implants, you can do the hormone levels without, because these methods do not mask that. And with Depo-Provera, if she is under 50, then they should stop to test FSH. But if she is actually over 50, the view currently is that her FSH will be rising in spite of being on Depo-Provera, and therefore you can do the tests. This is the second case. So this is a Matisse painting, which I like. This is a 48-year-old in a new relationship requesting contraception. So she says, listen, I've got 2 grown-up boys, used condoms as required. One of the things is to look at the unspoken flags. This using condoms as required, to me, reads, I haven't been having very frequent sex, and now I'm in a new relationship and I need to do something. She's a light smoker. She says that she's used the pill in her 30s and had no problems. Her periods last 8 days. They are becoming irregular and have been heavy for 5 years. So that is significant. That is the sort of person who says, I'm stoic, this is nature, I'll just carry on with my heavy periods. And she's getting more premenstrual symptoms in the past 6 months. She also reports that she's having night sweats the week before her period, which is the time when estrogen starts dropping. And I think with a relative estrogen deficiency, she can get vasomotor symptoms. So what are the issues? Red is the color of blood. So her menstrual problem is important. We should not ignore it any further. And the fact that she's been putting up with it for 5 years is not an excuse not to do anything about it. And therefore, we need to look into it. Her PMS, we think it is probably a marker for dropping estrogen levels. I think her request is a permission, 1, to have healthy sex, but 2, to also use something effective which will give her the freedom to enjoy sex. So it's the permission to use any of the methods of contraception that she wishes to have, and also permission to have help with her estrogen deficiency problems to allow her to have a full and very healthy sexual experiences. Smoking is a cofactor for her symptoms because it drops the levels of estrogen, and you need to talk to her about that, but it's also a risk on its own, and it will limit her choices, for instance, as far as using the combined pill. So let us look at the issues here. Bleeding, this bleeding, you may think, well, it is likely to be functional. She's had the heavy bleeding for a number of years. There's a change in the cycle, and that could be just an ovulatory bleeding. But I think this is an opportunity in someone who is in her late 40s to treat this as perimenopausal bleeding and to organize perhaps at least a pelvic ultrasound. Anybody who has had chronic heavy menstrual bleeding, you need to check their hemoglobin because anemia could actually be responsible for a number of the symptoms she is having. Her light smoking will affect her contraceptive choices, so she should not be using a combined hormonal method, and therefore you need to give her smoking cessation advice. If she stops smoking and stops it, for instance, for a year, she'll be eligible to use combined hormonal contraception. And any role for hormone therapy, I think there is, and we will discuss it in a minute. So you've organized an ultrasound, and the ultrasound shows that she has an intramural 40 millimeter fibroid, 4 centimeter fibroid, so something like this. The good thing about this is it is not impacting on the cavity, which means she can use an intrauterine method. The other important thing about fibroids is people panic about fibroids in women, for instance, who may need to use hormone, whether it's replacement therapy or whether it is a contraceptive hormones. And the net effect of most of the contraceptive preparations on the uterus is progestogenic, and therefore it is neutral as far as fibroids go. So do not worry about hormones stimulating the growth of fibroid. Her fibroid is of an average size, and intramural is not likely at this stage in life to cause her major problems. So let us look at her options. Combined hormonal contraception is an option if she stops smoking. This will regulate the cycle and is unlikely to affect the fibroid. A progestogen-only pill is safe, but may cause irregular bleeding. Remember, we now have the desogestrel progestogen pill, and we have the drospirenone progesterone-only pill, what we call DOP, the drospirenone-only pill. And these are improved choices. They are more effective, and they make, with desogestrel may cause amenorrhea. With drospirenone, a person who likes to have more regular pattern of cycling, that will give her more regular periods. And drospirenone, because of the effect on things like water retention, may also help her PMS. The IUD, again, I think it's an ideal method for women in the perimenopause, but she has heavy menstrual bleeding, and we need to consider that. Mirena, the friend of the perimenopause, is ideal because it allows you also to use systemic estrogen. Hormone therapy with sterilization, Nexplanon, very similar to the POP. Injectable, I think, for someone at this stage in the perimenopause is probably not a very good choice, and barriers as a backup. So this is my other slide of Barbie. This is when she was 48. And I think one of the very good choices for perimenopausal conception is Mirena, and I'm putting it here not as the IUS, because Mirena is the only IUS license for endometrial protection, or to use a combined hormonal method. This is what I call the all-in-one contraceptive, because it will give very, very good contraception. It's effective. The combined pill will relieve menopausal symptoms. Mirena would allow you to use systemic estrogen, which is good. Both are gynecologically protective. I'm going to show you a slide on the pill, but with Mirena, the reduction in heavy menstrual bleeding. And Mirena, the IUS, is free from medical risks. The combined pill, we need to consider things like venous thromboembolism, but for someone who is healthy, it is perfectly okay as a choice. And this is just a sort of a summary of where we are with the combined hormonal contraceptives. Is an appropriate choice. Many non-contraceptive benefits. The cardiovascular risk actually is small. People worry about things like arterial disease, heart attack, stroke. They are quite rare, even in pill users at this stage. We have safer options. We have 2 pills on the market which have natural estrogen, therefore they are metabolically safer. We were waiting for the epidemiology, and I'm told that with Glera we have some. With Zoli we should have something coming next year. And remember that Glera, which I'll talk about in a second, is also licensed to treat heavy menstrual bleeding because it has a very potent progestogen. I think if we're going to use the traditional pills, then 20 microgram pills may be better, and extended use is better. There is no point in someone who is having menopausal symptoms to actually have a break of 7 days. The hormone-free interval is now yesterday's practice, and duration of use has not much effect. The question about venous thrombosis is to express the risk in absolute terms. Per 10,000 women, you have 4.5 cases in non-CHC users, 9.5 with the COC, and about 40 in pregnancy. So this is Audrey Hepburn in Breakfast and Tiffany. The difference between using the pill and not using the pill is doubling of the risk in relative terms, but it's only 5 extra cases. So you're essentially looking technically at probably just these out of the 10,000. And there are a number of non-contraceptive benefits. I don't want to spend too long on this, but just to remind you that the reduction in ovarian cancer and endometrial cancer lasts years after a woman stops the pill and has saved a lot of lives in the lifetime of the use of the pill in the world. And there are a number of other benefits for the pill, including reduction in benign breast disease and pelvic inflammatory disease. Glera, just to highlight, is a estradiol valerate with Dianegest, licensed for contraception and management of heavy menstrual bleeding. This is the INAS study, which essentially shows from a VTE point of view, if you compare Glera to other combined pills, then the relative risk is actually smaller. If you compare it to microgynon, which is the standard 2nd generation pill, the risk is actually also smaller, but it's not statistically significant. So we can say it is at least as safe as a traditional pill. Zoli, again, a combination of estradiol with a potent progestogen, and the modern way of using the pill, i.e. a 24/4 regimen with only 4 dummy pills in the packet. It is a very good contraceptives also with the epidemiological safety hopefully coming sometime next year. Progesterone-only pills, as we've said, we have the traditional one, we have the desogestrel one, and we have the drospirenone one. They have low risk, high efficacy, and may protect the endometrium, not as part of HRT, but they do help, for instance, with heavy menstrual bleeding. They do not mask the menopause. Irregular bleeding needs sensible management, but if someone wants to have more regular periods, then drospirenone would be the one. If someone wants to have amenorrhea, then desogestrel would be the pill, and they will cause less dysmenorrhea. We've already talked about injectables. As far as IUDs and the IUS, the IUD, if fitted after the age of 40 can stay until the menopause. The IUS, if fitted after the age of 45, can stay to the age of 55. If you're using it for endometrial protection, you have to change it at 5 years. And all devices have lifespans longer than the license anyway. So we think the IUS in everybody can stay probably up to 7 years, and the IUDs can stay up to 12 to 13 years. We say that pregnancy is exceptionally rare over 55, and therefore, even if the woman is still menstruating, she's not very likely to be pregnant. And this is the idea of accepting the use of these methods beyond their licensed life. In my patients, if they say, well, what if I fall pregnant at 56? I say, well, there will be good news. You'll be in the Guinness Book of Record or something to that effect. Barriers are fine as backup. They're okay if the couple are already familiar with them. Hormone therapy for the perimenopausal symptoms. We've talked about the pill. Vaginal estrogen is okay. Progesterone-only pill with sequential combined, Mirena, and we've talked about barriers. I'm going to skip the last case. The last case was really to highlight a couple of things, mainly that someone who is in a relationship may need STI screening, and that this lady was using an IUD. We can do endometrial sampling with the IUD or the IUS. I want to finish with my conclusion. The perimenopause is a time of opportunity for us to explore a healthy lifestyle with the patient, a time for risk minimization, looking at signs of risk, red flags, a time where we need to be very clear about the safety of contraception and the advantages of hormone therapy, a time where a woman wants to be optimistic about her potential, and we need to keep the dialogue going. So this is where I lead you to Doc Matter. We can connect with the questions. You can submit them in relation to this webinar to Doc Matter ESC. And this is a benefit. If you're interested in accessing the community, but are not yet a member, then go to info@ESC/EU and follow the lead from that. Again, the benefits of the membership of the ESC are many, and as Johannes was pointing, it's really good value for money. And this again is my plea to see you in September in Ghent. Good beer, good chocolate, good walks, good culture. So hopefully we will see you then. And thank you very much.
Thank you very much, Ali. We have already some questions which we will discuss afterwards. But now I would really very much like to invite Anna Glasier to tell us about using emergency contraception after missed oral contraceptive pills. I think this is a very, very important issue, and I'm really looking forward to what Anna has to tell us about it. Thank you very much, and please, Anna, go ahead.
Okay, thank you, Johannes, and greetings to everyone from Scotland. As Johannes said, I'm going to talk to you this afternoon about a very specific issue, which is using emergency contraception after missing oral contraceptive pills. And I'm going to be even more specific and talk only about using ulipristal acetate, or ELA-1, or in the US, ELA, as an emergency contraceptive after missing oral contraceptive pills. Now, first of all, my conflict of interest. I've worked for a very long time as an independent consultant to the company HRA Pharma in Paris, who market both levonorgestrel emergency contraception in Europe and ulipristal acetate emergency contraception in Europe and in the USA. I'm going to talk to you about a particular study that HRA Pharma did. I helped design the study, and with Camille Barn, who is the first author, I wrote the paper. So I'm going to start by reminding you that women who use emergency contraception after unprotected intercourse continue to be at risk of pregnancy unless they start effective contraception. And in the early days of emergency contraception, the advice to women was to wait until the onset of their next menstrual period in order to be sure that they weren't pregnant before they started a contraceptive method or restarted a contraceptive method. But following some elegant work by Carolyn Westhoff, the recommendations changed to say that women should start their method of contraception immediately after using emergency contraception if they wanted to prevent themselves from getting pregnant. And this is the cover of the Faculty of Sexual and Reproductive Health Care in the UK clinical guidance on quick starting contraception, which is what starting contraception immediately after EC came to be called. But also in 2010, ELA-1, the ulipristal acetate emergency contraceptive, was launched on the European market. It is, as you very well know, an emergency contraceptive which is licensed for use up to 5 days after unprotected intercourse. Its principal mode of action, and I'm reminding you of this because it's important for understanding the study that I'm going to tell you about. Its principal mode of action is to delay ovulation for up to 5 days after it's been taken, And it is, of course, an anti-progestin. And so people began to express concerns that if you quick started your hormonal contraceptive immediately after using ELA-1, ulipristal acetate, would the anti-progesterone in some way interfere with the effectiveness of the quick-started contraceptive? So would using ELA-1 for emergency contraception and immediately starting, let's say, a combined oral contraceptive pill, result in a reduction in efficacy of the combined oral contraceptive pill? Now, Sharon Cameron, one of my colleagues in Edinburgh, published a study in 2015 which showed that that didn't happen, that if you started a combined oral contraceptive pill immediately after using ulipristal acetate for emergency contraception, you didn't jeopardize the efficacy of the combined oral contraceptive pill. But Sharon didn't look to see whether anything happened to the efficacy of the emergency contraceptive. So also in 2015, Vivian Brache from the Dominican Republic published a study in which she looked at the two questions. If you quick start, in this case, a progestin-only pill containing desogestrel, immediately after using ulipristal acetate for emergency contraception, did you either jeopardize the efficacy of the desogestrel pill, or did you jeopardize the efficacy of the emergency contraceptive? Now, I'm not going to show you the data for saying this, but the data on the efficacy of the POP were reassuring, and there was no evidence that UPA did jeopardize efficacy of the POP. But there was evidence that starting the POP the day after using ulipristal acetate for emergency contraception significantly reduced the effect that ulipristal acetate had on delaying ovulation. And this was a statistically significant result. So very briefly, 29 women took ulipristal acetate, 30 milligrams, followed by a placebo, and ovulation occurred in the first 5 days after ulipristal acetate in only one cycle. That was 3%. But if in the 29 women who took ulipristal acetate followed immediately by desogestrel, ovulation occurred in the first 5 days in 13 of the 29 cycles, which was 45%. So clearly an increase in the number of women ovulating when the main mechanism of action of ulipristal acetate is to delay ovulation by 5 days. Now, a couple of years later, in 2018, Alison Edelman from the USA published a very similar study, but on this occasion, the women took a combined oral contraceptive pill, and they started it 2 days after using ulipristal acetate, and showed the same thing, although the effect was weaker, that if you started your combined pill very soon after using ulipristal acetate, you reduce the ability of ulipristal acetate to delay ovulation, and therefore theoretically may jeopardize the efficacy of the emergency contraceptive, which you'd taken because you had had unprotected sex. Now, it's important to understand both of these studies, in fact, all three studies, Sharon Cameron's study, Vivian Brache's study, Alison Edelman's study, all explored the effect of starting hormonal contraception for the first time after taking ulipristal acetate emergency contraception. They were normally cycling women and not women who were already using the pill and had taken emergency contraception for missed pills. And both the Brache and the Edelman study, and in fact the Cameron study, they all deliberately administered ulipristal acetate emergency contraceptive when there was a mature ovarian follicle of around 18 millimeters in diameter. The idea being that we needed to show that at the riskiest time in the cycle, what would be the worst case scenario if a woman took ulipristal acetate in the presence of a mature ovarian follicle and then started to take the pill. So what happened as a result of Vivian's study and then confirmed by Alison's study was that the Faculty of Sexual and Reproductive Healthcare in the UK and other organizations nationally and internationally who write contraceptive guidelines published advice saying that while after taking levonorgestrel emergency contraception, women could start hormonal contraception immediately, although they should use condoms or abstain from sex until contraception became effective. In contrast, if a woman took ulipristal acetate emergency contraception, ELA1 or ELA, she should wait for 5 days before starting her hormonal contraception, and she must use condoms reliably or abstain from sex during the 5 days of waiting, and then until the contraceptive method which she starts 5 days later became effective. But neither the Brache study in 2015 nor Alison Edelman's study in 2018 studied women who had taken emergency contraception because of missed pills. Nevertheless, the guidelines also said that if people took emergency contraception for missed pills, if they took levonorgestrel for emergency contraception, they could restart their pill immediately. But if they took ulipristal acetate for emergency contraception, they should wait 5 days before restarting their pill, whether it was a POP or a COC. Now, if you stop to think about it, that doesn't really make sense, because we know that if people are on a combined hormonal contraceptive pill, ovarian activity is suppressed, ovulation is unlikely, and it takes time for the suppression of the ovary to recover when pills are stopped. And in this systematic review published in 2013 by Lauren Zapata and Kate Curtis and others, they looked at the effect of missing combined oral contraceptive pills on the effectiveness of the pill. And they reviewed 19 studies which had examined ovarian function during cycles in which pills were deliberately missed for a range of consecutive days, sometimes deliberately extending the pill-free interval, and some of them also examined the effect on cervical mucus. And they concluded that in general, the risk of ovulation was low, even if up to 4 pills were missed adjacent to the pill-free interval. So 7 days without a pill and then 4 missed, which is 11 days without a pill. They went on to say that if women did ovulate, and there weren't very many of them, cycles were usually abnormal with low progesterone levels, small follicles, and/or poor cervical mucus. So we hypothesized that restarting a combined oral contraceptive pills after missing pills and using ulipristal acetate emergency contraception would in fact be very unlikely to result in ovulation, because ovarian activity would be suppressed and follicle growth would be unlikely to reach the pre-ovulatory stage in the 5 days following use of emergency contraception, when UPA would be expected to be active. We did the study. It was published this year in Contraception. Camille Barn from HRA Pharma is the first author. And I'm going to tell you exactly what we did in the study and what the results were. So we recruited 54 women. They were monitored during 2 cycles of combined oral contraceptive pill use. It was a 30 microgram methanol estradiol pill in combination with 150 micrograms of levonorgestrel. They were monitored for 2 cycles. The first cycle was a baseline cycle, and then the second cycle, which started after a 7-day pill-free interval, was the cycle in which they were exposed to UPA. So in cycle 2, on the first day of taking the new packet of pills, transvaginal ultrasound was performed to identify any existing ovarian follicles, and women were randomized into 2 arms of the study, taking care to make sure that there were equal numbers of women in each arm who already had an ovarian follicle present on day 1 of pill taking, and dividing those ovarian follicles into those less than 10, between 10 and 13, and more than 13 millimeters. The women took the pill for 4 days, and then they all deliberately missed their pill on 3 consecutive days, so 5, 6, and 7 of the packet. And on the morning of day 8, all of them took a single tablet of ELA1 ulipristal acetate 30 milligrams. Then the women were divided into 2 groups. The immediate restart arm, so these women immediately restarted their combined oral contraceptive pill that same evening on day 28, and 26 women completed this arm of the study. The other arm was the delayed restart arm, in which women did what the recommendations told them to do. They waited for 5 days and then they restarted their pill on day 13 of the packet, and 23 women completed that arm of the study. All of the women were closely monitored with transvaginal ultrasound and measurement of estradiol and progesterone on frequent days through the pill packet in this second cycle. And if a follicle of more than 15 millimeters was seen, monitoring frequency was increased so that it was done every day until either a post-ovulatory image was seen on ultrasound or estradiol had fallen to less than 0.1 nanomoles per liter. And ovarian activity status was determined using an algorithm which was based on follicle diameter, the presence of a post-ovulatory follicle on ultrasound, and on the concentrations of estrogen and progesterone to determine whether the ovary was quiescent, whether there was ovarian activity in the form of follicle growth, or follicle growth but an inadequate luteal phase, so that women were not at risk of pregnancy, or whether there was ovarian activity with an ovulation with a normal luteal phase, and therefore, had they had intercourse, these women would theoretically have been at risk of pregnancy. So what were the results? During the 5 days after taking ulipristal acetate 30 milligrams, no one in either study arm ovulated with a normal luteal phase, which would have put them at theoretical risk of pregnancy. In the immediate restart arm, those women who started their pill on the same day as they took ulipristal acetate, only one woman showed evidence on the scan of ovulation. She had an ultrasound on day 30, which made it look as though she'd ovulated on day 13 of the UPA exposed cycle, but her progesterone levels remained less than 10 nanomoles throughout. In the delayed restart arm, where women waited 5 days, 4 women, that was 17.4% of them, ovulated. All of them had a normal luteal phase according to their progesterone levels, 1 each on days 15 and 17 and 2 on day 16 of their pill packet. So in the immediate restart arm, there was evidence of ovulation with an abnormal luteal phase in 1 woman. In the delayed restart arm, there were 4 women who ovulated normally. And this difference between the 2 treatment arms with respect to the occurrence of ovulation and therefore the theoretical risk of pregnancy was statistically significant. I'm just going to show you one picture, one figure, which looks on the top, looks on the top panel at the immediate restart cycle and the delayed restart cycle, but during the baseline. So in the blue bars are ovarian quiescence, in the orange bars, ovarian activity, but without theoretical risk of pregnancy. And you can see there's really no difference between the women who, in the baseline cycle, between those who were randomized to the immediate restart and those who were randomized to the delayed restart. On the lower panel, the immediate restart arm, the blue is ovarian quiescence, the orange is ovarian activity, but not at theoretical risk of pregnancy. And in the fourth panel, these are the women who delayed restarting their pill for 5 days. You can see there's much more ovarian activity, much more orange on this figure, and there's red on this figure, which there isn't on the previous panel. And red is defined as ovulation and at theoretical risk of pregnancy. So if women waited 5 days, they were much more likely to have ovarian activity and they were much more likely to ovulate, even although they restarted their pill on day 13 and so could have been at risk of pregnancy. So what does this tell us? If women who use ulipristal acetate emergency contraception after missing combined hormonal contraceptive pills wait for 5 days before restarting their pills, they are in fact at much greater risk of ovulation and therefore of pregnancy than if they were to restart their pill immediately. What don't we know? Well, we don't know what would have happened if these women hadn't used emergency contraception at all, because we didn't do a placebo arm. But actually we do know, because Zapata has told us in their review that if women miss up to 11 pills consecutively, then they're very unlikely to ovulate. So we didn't see the need to do a placebo arm. Would the same apply to women using other combined hormonal contraceptives, pills, patch or rings? Well, there are studies where people have deliberately misused, or rather deliberately missed doses of their patch or ring, and it seems logical to assume that the same would apply, that these women would be better to restart their patch or ring immediately. What if a woman missed only 1 or only 2 pills? Well, in general, for the combined oral contraceptive pill, women aren't advised to take emergency contraception if they miss only 1 pill. And if they miss 2 pills, it depends on when they've missed it. But it seems to me unlikely that women who miss only 2 pills would have a different result from the women in our study who missed 3. What if she missed more than 3 pills, 4, 5, 6 or 7 pills? Well, of course, the more pills you miss, the more likely you are to ovulate and be at risk of pregnancy. But if you imagine a woman who, let's say, has a 7-day pill-free interval and then forgets 6 pills, giving her 13 days of not having a pill, then of course she's going to be more likely to ovulate and more likely to be at risk of pregnancy. But a study published in 2019 in Contraception, a modeling study by Bullard as the first author from Alison Edelman's group, showed that ulipristal was more effective than levonorgestrel for emergency contraception in every situation, including if emergency contraception was taken after missed pills. And they calculated that the efficacy of ulipristal had to change by 160% before it became a better option to use levonorgestrel. What if missing pills extended the pill-free interval? I think I've covered that. Would the same apply to women using the POP? We don't know. We haven't done that study. And so I can't tell you what would be our advice for women using a first-generation POP, a desogestrel POP, or a drospirenone POP who missed pills and used emergency contraception. And I think at the moment we don't have grounds for changing the guidelines. So my conclusion to the paper was that it was time to revisit the guidelines. That was going to be my conclusion in my talk today, but I received an email this morning from the Clinical Effectiveness Unit of the Faculty of Sexual and Reproductive Healthcare telling me that they had yesterday released new guidance. And I show you here a slide, FSRH CEU statement response to a recent publication regarding Barn et al., paper that I've just been telling you about. And in that guidance, which is available to you at the FSRH website, they say, on the basis of this new information, FSRH CEU makes the following recommendations. If EC is considered to be required in the specific situation in which an established combined hormonal contraceptive user restarts combined hormonal contraception after a hormone-free interval and then misses between 2 and 7 pills in the first week of pill taking, or makes an equivalent error with a combined patch or ring, then levonorgestrel emergency contraception may be offered with immediate restart and use of condoms for 7 days, no change to the guidance. But if ulipristal acetate is preferred, and remember I've just told you that the models suggest that it's more effective than levonorgestrel emergency contraception in all circumstances, if ulipristal acetate emergency contraception is preferred, it may be offered now with immediate restart of combined hormonal contraception and use of condoms for 7 days. The Clinical Effectiveness Unit has told me that they're revisiting the emergency contraception guidelines, so more advice may change, but for now, this is the new advice, which is being recommended on the basis of the paper that I've just told you about. So as a result of that, I've changed my conclusion to this presentation, and my new conclusion is, if you want to know the answer to a question, then do the research. Thank you.
Thank you very, very much, Anna, for this really exciting insight into this important study, which has, of course, an impact on our practice in this field, in this everyday field of missed pill and management of missed pills. I have received several questions, which I would like to discuss with you. We have a little bit of time. Maybe we start first with questions which are addressed to Ali. One of these questions is, can women use combined hormonal contraception and traditional HRT at the same time? I don't know why you would want to do that, but can you give an answer? If so, are the risks increased? They are probably increased because you have a higher dosage.
Okay, thank you, Johannes. I think that would be overkill for a number of reasons. One, because if they are on the pill that is giving them really, really good contraception, it will double the cost of contraception to your healthcare system and to the user. I think if you are worried about someone using the combined pill with a synthetic estrogen, such as ethinyl estradiol, we now have two options, which is the two pills I've mentioned, one with estradiol valerate, that's Clara, and one with estradiol, and that is Zoli. And these are contraceptive, but they also are using natural estrogen. So if you feel a woman is estrogen deficient, she is actually getting her replacement from that pill. So my recommendation is to go for these two options, these two pills. Right. In the UK, Zoli is not, easily available, but Clara is definitely. And I think they are good options. They also use very potent progestogens, which means that they give good cycle control. Right.
Another interesting suggestion came in early. What about the possibility to use drospirenone plus transdermal E2, which is of course not a product, but it's
yeah. So maybe the question that we normally get is, can someone using the progesterone pill just add estrogen? And of course now drospirenone has a pill, which is what we call DOP. I think in Europe it's marketed as Slinda. There is no work demonstrating that there is endometrial protection from a progesterone pill. So I don't think you can use that combination as a matter of fact. I think if someone is on a drospirenone pill and gets menopausal type symptoms, you can add sequential combined therapy, and we do that quite a lot. And the way you explain it to the woman is say your POP or DOP, as with drospirenone, gives you contraception, and I'm going to add something which will relieve your symptoms, and the two do not, as a matter of fact, clash. And the important thing with both desogestrel and drospirenone is that they inhibit ovulation. So you are even more sure about contraceptive.
Right. A question in the same direction, very briefly. If Mirena is applied for endometrial protection with estrogen, with estradiol, replacement, is there any age limit?
I don't think so. I'm going to just try to read the question, I think.
If Mirena is applied for endometrial protection with estradiol replacement, is there any age limit?
Well, Mirena, as far as the license for endometrial protection is 5 years, and it's based on, obviously, the research. As Anna was saying, if you have a question, you do the research. And therefore, I think if you are using Mirena with systemic estrogen, it needs to be changed every 5 years.
Okay. An important issue comes from our friend Franz. A minimal but significantly increased risk of breast cancer has been demonstrated in premenopausal users of LNG-IUS, the study of Mork et al. From Denmark. How do you discuss this with your premenopausal woman?
Well, as you know, as far as breast cancer, a woman with breast cancer, Mirena is what we call a MEC4, it's a contraindication. I think if you have someone who is worried about the risk of breast cancer as far as hormonal contraception, the counseling is along the same lines as we do with all other hormonal methods of contraception, which is If there is a risk, then the risk is small. The risk then decreases once you stop the contraceptive. And I don't see a fear of breast cancer as a reason not to use Mirena long term. But Mirena currently, for a population advice, is contraindicated in someone with breast cancer. But I can tell you that in individual cases, someone who's a survivor of breast cancer, you can have a discussion, and you may even allow to use Mirena, because it also reduces the chances of endometrial polyps.
Well, and maybe we have to acknowledge that the MORC study has been criticized also for methodological limitations. Now, very briefly, because we want to go to Ms. Pill, one last question to you. What about implants in perimenopause?
Yes, they are a definite option. As you know, we feel that implants, subdermal implants, can probably be used up to 4 years. They don't offer endometrial protection. So again, the same rule applies as with the other methods, but they are choices, and they are good choices. And I think the important thing is that the woman is properly counseled, because as you know, if she gets any anxieties about irregular bleeding or anything like that, there is a procedure which you have to remove the implant. But it is an excellent choice, and it's obviously the most effective contraceptive method that a woman can use.
Thank you. Now, Anna, if I may ask you some questions. What would be the benefit of immediate restart of COC and UPA over the continuation of COC with LNG emergency contraception?
Well, I think if you read the paper by Bullard in Contraception, the modeling that they did shows that, or they concluded that ulipristal acetate was more effective than levonorgestrel. And I've always argued that in these circumstances, you have a woman who has definitely had unprotected sex, for which she uses emergency contraception. And then you're giving her advice about what to do next to prevent herself from getting pregnant from subsequent acts of intercourse which haven't yet happened. Which would be your major concern, the sex that had happened or the sex that might happen? Because for me, it would be the sex that had happened, in which case I would rather use the more effective method of emergency contraception.
Thanks very much. How many times in a cycle can a woman use LR1 for emergency contraception?
I would say as many as she needs to.
Okay, very short and precise answer. Regarding the woman having missed some pills and then getting UPA, would the fact that she has received some hormones within the 7 days preceding UPA not affect its efficacy also? So the impact of having had hormones before, would that reduce the antiprogestin action?
No, I don't think so.
Yeah, I think, yeah.
What we're concerned about is what happens if they start it afterwards, because ulipristal acetate doesn't act retrospectively. Its action happens after it's been taken. So that's what we're interested in.
Right. So I think I don't know how much time do we still have for questions, because there are some more perimenopausal questions coming in.
We have time, Johannes. There is time.
Do we have time? Okay. Could we use Mirena after 50 plus estradiol for treatment of menopausal protection? I think you
ideal. It's an ideal method because you are using systemic estrogen. You avoid the side effects of oral or transdermal progestogens, and it's really quite a good combination. As long as you're using it for 5 years, and it will give amenorrhea, and the amenorrhea increases with the duration of use. So it's good all rounder.
Okay. And then there was this question about, would you use also Levocert, although it's not licensed for endometrial protection?
If it ever gets licensed for endometrial protection, yes. I think if you're using it as a contraceptive, as you know, it is a very good comparable contraceptive, and it will also manage heavy menstrual bleeding. So I think for the perimenopausal woman who is not requiring systemic estrogen, Levocert is as good an option.
Another question to Anna: when using copper IUD as an emergency contraception and not wanting to use it as a regular contraception, which may happen, when would not want to continue to use its regular contraception? When would starting COC again? You understand what this meant? You have put in the IUD for emergency contraception, but you don't want to keep it. You take it out, and then when would you start with the COC? Immediately, no?
Yeah.
Well, you could start immediately, yes. I don't see that you lose anything by starting immediately. The only thing is that you would then probably interfere with the time of bleeding. Mm-hmm. And so you might end up keeping the IUD longer than you really need to, but I don't think that's a particular disadvantage.
Okay. Yeah, that's what Mirena is applied for endometrial protection for 10 years. This is a question from Argentina. Is it correct? Can you use it for 10 years for endometrial protection?
Well, you have to change it at 5 years. You can use it for endometrial protection as long as the woman is taking estrogen, but you have to change it at 5 years. The license and the research is based on a 5-year cycle.
Also for endometrial protection, you mean? Or?
Yeah, for endometrial protection, I think the research, the evidence is based on a 5-year cycle, and therefore it has to be changed at 5 years.
Okay. Yeah, more questions are coming in. In the case of emergency contraception for missed pills, would the choice of EC pill be influenced by the timing of the last unprotected sex? Say if the pill has been missed for 5 days in the first week and UPSI happened, unprotected intercourse happened 4 days ago, would LNG still be the choice?
LNG wouldn't be my choice. UPA would be my choice.
Yeah.
I mean, I think what the idea that I've been trying to get across is that if women are taking the combined oral contraceptive pill, and that's what we're talking about, and they miss pills, it takes a long time for ovarian activity to recover. Neither ulipristal acetate nor levonorgestrel, as far as I know, will stimulate ovulation. So I don't really see that the timing of intercourse makes any difference to what would be your choice of emergency contraceptive.
Okay. Is it possible to use Mirena for emergency contraception?
Well, I think there was recently a paper published by David Turok from the States suggesting, yes, it is.
Yeah, I mean, there was this concerns in Europe about if you would, in the case of failure, have malformations or anything. Yeah.
Well, I mean, it's a very small dose of progestin. Yeah. There's no evidence that progestin-only contraception, or indeed combined hormonal contraception, is associated with teratogenesis.
Yeah. Well, it may be just for, yeah.
But, you know, as I say, David Turok has recently published a paper showing that it is effective. I guess your concern about inserting Mirena for emergency contraception, maybe it's quite expensive. So if the woman didn't want to continue, then it would be rather an expensive method of emergency contraception.
Another question, LR1 can be used up to 5 days from the date of unprotected sex.
Yeah.
Does it work as abortifacient?
No. There's no evidence that it works as an abortifacient. And up to 5 days after unprotected sex, implantation is not going to have occurred. There's no evidence from any of the studies of 30 milligrams of ulipristal acetate of an increase in the risk of miscarriage among women using it for emergency contraception. It's not an abortifacient when used as an emergency contraceptive.
What about forgotten pills in the last week of the strip and having a pill-free week thereafter? When would you take the emergency contraception if you have had an unprotected intercourse in the pill-free week?
I think you would take it as soon as you could, because whenever you've had intercourse, the sooner you take ulipristal acetate or indeed levonorgestrel, the more likely it is to be effective. So it doesn't matter when you miss your pills or when you have intercourse, the message is still the sooner the better.
No. And that wouldn't have an influence on the contraception afterwards?
No.
No. Mm-hmm. If the IUCD is close to expiration date, can it be inserted into the woman?
Is that a question for me or for Ali?
Maybe for you.
Well, even if it's close,
for both of you.
If it's close to the expiry date, it's still going to work as an emergency contraceptive. It would seem to me a little unkind to insert a method, an IUD that was close to its expiry date, if somebody wanted to use it as a continuing method of contraception, unless you thought that the woman herself was close to her expiry date.
And our colleague asks again, because obviously in their place, we have quite a lot of IUCD supply that will be expiring the end of this month and some next month. So that seems to be a local problem.
Johannes, I actually think that legally you can use an IUD if it is not expired, i.e. if it is within its expired date. We do know there is a debate currently in one of the forums, I'm not sure whether it's in Doc Matters, about expired using, paying attention to the expiry date of medication, because a lot of these are also sort of slightly work on what the license is also for. And we know that, for instance, for IUDs, you can actually use them longer than their licensed life. So I think if you are in a country where women do not have access to a lot of the other options, and you have an IUD which is not expired, maybe close to expiry, I think it is actually legally and ethically perfectly okay to use it.
Yeah, it would be a waste to throw it away, wouldn't it?
Yeah.
And how long would you keep it in for, Ali?
Well, I think legally it is not expired, and therefore it can be kept in for its licensed life, in my view.
But you wouldn't keep it beyond.
I think this is also an issue, and it is all about talking to the person. You might say, okay, nothing else has happened. I have. Maybe you can keep it for 3 years rather than 5 years, or 5 years rather than 10 years. But I can't see a method which is within its expiry date being not subject to the license sort of specifications. Right. Legally, I think it's perfectly okay.
I mean, you are supported by Anwerkungsstreit. The date is until you can insert it.
Yeah.
Not until it is effective. Yeah. Very good. Dr. Anna, how far from the expiration date would you suggest is safe to insert? Well, that's the same question. So the expiry date is actually about the use and not about the duration of action. Mm-hmm.
Yeah.
That would be stupid somehow, wouldn't it? Yeah. Okay. Let me see if we have answered all the questions. We have the abortifacient, we have everything, and woman. We have a question about breast cancer. Yeah. Right.
Johannes?
Yeah.
I mean, if we have no questions, we still actually have 10 minutes of the webinar.
Yeah.
I've missed the last case in my presentation. Do you want me to go? There are only 3 slides. Do you want me to go?
I'm
back?
sorry, there is a huge question now coming in.
Okay.
In the last 2 years, healthcare professionals received several letters from EMA that intermittent usage of ulipristal acetate 5 milligram daily for curing fibroids could have potentially harmful effect, you know, the hepatotoxic effect of the fibroma treatment. Considering fact that in LR1 there is 30 milligram of UPA in single dose with a T-half of 32 hours, it means that after ingestion of only one 30 milligram LR1 pill, women's hepatocytes are exposed to higher or same level of UPA for 140 hours or 6 days, or in slower metabolizer, it could be up to 190 hours for 8 days. So finally, the question comes to the issue, wouldn't we be concerned that you have hepatotoxicity with the use of UPA? Would we need more studies? Where is it now? Here, yeah.
Well, my answer to that would be that tens of millions of women have now used UPA for emergency contraception, and there's never been any signal of hepatotoxicity. And the EMA specifically excluded use of UPA as an emergency contraceptive for their advice regarding not using UPA 5 milligrams a day for fibroids. So the EMA doesn't think there's an issue. And the evidence is that millions, tens of millions of women have used, more than 10 million women have used UPA for emergency contraception without any signal of hepatotoxicity.
Yeah.
So I don't think there is a concern.
Okay. There are other questions which are answered now about the expiry date. There is another question to Ali. How long can you take HRT for?
There is no time limit. The American Society and indeed the International Menopause Society and our UK Society do not put a sort of like a cap on the number of years. You need to review both the indication, the side effects, and the risk factors. And you know, whether you do a review as you normally do every year when you're checking the woman or every couple of years, I think the questions to ask is, do you still need contraception? So do you still need HRT? In the sense, do you have symptoms? Are you worried about the duration of use? What I tend to tell my patients is they can use it as long as they have not developed risk factors. Yeah. But I also say that if the woman is anxious about continuing to use HRT for a long period of time, there is no harm in having a trial discontinuation. You know, a lot of people think I'm going to stop, I'm going to get terrible symptoms, or I'm going to upset my hormonal milieu and, you know, we'll never get back to normal. I tend to say, listen, use a break. Don't use a break of just 2 or 3 weeks. You need to probably have 2 to 3 months to see if the initial return of, for instance, vasomotor symptoms will then decrease. And then you need to make a decision about long-term. But there is no, limit. And I, not now, but when I was younger, I looked after a woman who actually was figured on the BBC World Service at one time, who is the longest user of HRT in the world. She had started HRT after a hysterectomy at the age of 45. She died at the age of 87 from a colon complication, and she was still taking HRT.
But probably, if you agree, probably it's different if you start late.
Yes, of course.
Because of vascular complications.
Yeah.
You wouldn't want to.
Yeah.
Because that's probably the difference. If you have a long-term intake. It protects.
And I mean, you know, to tell you a story, it is quite interesting. This lady came to me because she was on the charity committee for guys in St. Thomas's Hospital. So someone said, we must look after her because she gets us a lot of money. And the reason why she wanted to carry on with the charity is at the age of 85, she was still very active in going to committees and to charity boards, and she wanted to be in charge of her faculties. And I think that is the absolute essence of quality of life with hormone therapy.
Yeah, that's right. And okay, so I don't see any newer questions. Couple of minutes left. Time to, I get the message that, you know, I'm under the time to conclude. Yeah, maybe because we're only couples of minutes. So if there are no more questions, I first of all want to thank, of course, Anna and Ali for these excellent talks. I would really like to thank all the participants for their questions. It was a very lively session, which I think we all enjoyed very much. For coming to an end, I really want to remind you again that this type of discussions can go on. Also the questions you have and you could not put on now, or which come to your mind after thinking about the webinar, please go to, please first of all, if you're not a member, become a member. And if you are then a member, then please go to the Doc Matter connection of ESC, and please ask your questions, give your input, give your feedback. I think that would be very, very helpful for us as a society to understand what the questions are and what the needs are, because this is the basis on which we would build our activities. So, yeah, I think that's the last slide actually. Thank you all again for having participated in today's webinar, and wherever you are, I wish you a nice evening, and I know that Ali and we will have a drink. Each one has his place. Thank you very much.
Bye-bye.
Bye, everyone.
Bye.